Salam to all of you. We come to a second question, which is morphology, pathophysiology, the different stance used in optical and microscopy, and finally, the diagnosis of amyloidosis. I am Professor Ghalia Khlaf, nephrologist at Mohamed Lamine Debarine Hospital in Algiers, and together we will see the details of our interrogations. We begin. There are different formation mechanisms of amyloidosis, and amyloidosis pathway, an integrated view of amyloid formation. This figure illustrates the three main pathways of amyloid fibril formation in amyloidosis: acquired, inherited, and wild type. In acquired amyloidosis, increased level of certain SAA and beta-2 microglobulin misfolded proteins aggregate under the influence of amyloidogenic factors such as amyloid P, ApoE, and GAGs. In hereditary amyloidosis, mutated proteins undergo proteolytic cleavage, resulting in the formation of amyloid. In wild-type amyloidosis, the native proteins don't fold spontaneously, particularly with aging. It's ATTR. Despite their different origins, all pathways converge in the nucleation phase, leading to the formation of insoluble amyloid fibrils characterized by a cross-laminated structure. We are going to classify this amyloidosis. We say that amyloidosis is classified according to topography. There are localized and systemic amyloidosis. Systemic amyloidosis is subdivided into secondary, hereditary, and primary forms. Localized amyloidosis differs from systemic amyloidosis in that it's affected only the brain, such beta protein precursor for Alzheimer's disease, alpha-synuclein amyloid protein of Parkinson's disease, a prion protein for Creutzfeldt-Jakob disease, ABRI precursor protein, a normal precursor of the amyloid protein of British familial dementia in the human brain, and ADAN precursor protein for Danish familial dementiate eye. And other condition it can affect. We are speaking about ocular here, and say that gelzolin, lactoferrin, and keratoepithelin can aggregate in the eye. Others localization, we can see calcitonin can affect medullary thyroid cancer, amylin 4, which affect pancreatic beta cells in type 2 diabetes, prolactin in hypothalamus tumors. The bladder can be affect the skin with keratin, midin in blood vessels. Amyloidosis. The biochemical properties of amyloidosis. These proteins either originate from protein expressed by cells at the site of deposition, which seems localized, or they precipitate systematically after being produced at a local site, systemic. In humans, around 23 different unrelated proteins are known to form amyloid fibrils in vivo, and we'll be looking in major forms and minor forms, and we are going to speak about AA amyloidosis and AL light chain amyloidosis in details. What are the most common amyloid protein preferential location? For the kidney, we can see AL, AA, a fibrinogen, ATTR muted. For the heart, AL, ATTR wild, ATTR muted, AA, and fibrinogen. For the digestive tract, we can see AL, AR, AA, ATTR, wild and muted, fibrinogen. For the liver, AL, AA, and fibrinogen, and for the neurologic, for the tract neurologic, we can see AL and ATTR. What is organic pathophysiology for all the organs? In the early stage, there are a few deposits of amyloid protein. This early stage may even be asymptomatic, but the more the mass of protein increases in the organ, the more biological or radiological symptoms develop of the organ increases in size. In the final stage, the extracellular damage is so extensive that it causes pressure and atrophy, and the addition of vascular damage, which may be in its early stages, will accelerate the ischemia of the organ in question and lead to organ dysfunction. For the kidney, it's the same. The deposit of fibrin amyloid in the glomerulus and in the interstitial deposition can lead to pressure and atrophy for adjunct cells, and ischemia and pressure and local atrophy can lead to end stage of renal disease. Organ most often affected by amyloidosis. Microscopically, the kidneys may be normal in size and color or enlarged. In advanced cases, they may be shrunken due to ischemia caused by vascular narrowing induced by amyloid deposition in the arterial and arterial walls. In light microscopy, stains such as hematoxylin, eosin, or Masson's trichome can alert us to the presence of an amorphous eosinophilic substance. But diabetes can give similar image. The two stains most commonly used to mark amyloidosis are Congo red and theoflavin, and those which determine the origin of the proteins such as AA against ATTR, and in immunofluorescence to against lambda and beta chain. But the problem that the immune serum is very expensive in our country. On the light microscopy, amyloid is deposited mainly in glomeruli. The glomerular deposit appears as a subtle thickening of the mesangial matrix accompanied by a nerve of the glomerular basement membrane. Here, deposition along the membranous glomerule causes capillary narrowing and distortion of the glomerular vascular tuft. As glomerular amyloidosis progresses, the capillary lumens become obliterated and the obsolescent glomerulus is flooded by confluent masses of large ribbons of intertwined amyloid. This is a renal prognosis of deposition of amyloidosis. Class 0, no amyloid deposits. Class 1, minimal mesangial deposits under than 10%. Class 2, slight mesangial deposited under between 10 and 25% of deposition. Focal deposit in class 3 between 26 and 50%. Class 4, diffuse deposit between 51 and 75%. The fifth class is membranous, and the advanced class in class 6 is up than 26%. But other than the glomeruli is the most renal deposition, and it's about 97%. Vessels about 86%, interstitium about 58%, and tubular basement membrane about 8%. In light microscopy, the vessels and interstitium are also affected. Here we can see in the interstitial, and here in around in D around the vessel, and in C in the vessel. We can see here in the image A, sclerosed glomeruli with amyloid deposit, in B, peritubular amyloid deposition, in C, intravascular deposit, and in D, amyloid deposit around blood vessels. Immunofluorescence serum immunosorbents, anti-heavy and against heavy and light chain. Here we can see normal glomerulus with open capillary lemons. Here amyloidosis with deposit obliterating the glomeruli, and here monoclonal hemoglobin deposition disease with deposits distorting the glomerulus. Here no immunoglobulin deposit at immunofluorescence, and here we can see light chain and heavy chain detected by immunofluorescence. Immunochemistry against AA and LEG2 and ATTR. In hematoxylin and eosin stent section, in A, shows the accumulation of amorphous and slightly eosinophilic material in the glomeruli, arterioles, and interstitial zones. Immunochemical staining for SAA in B confirmed the presence of AA amyloidosis. What is biochemical properties of amyloid light chain amyloidosis? Precursor protein, complete immunoglobulin light chain, aminoterminal fragment of the light chain, or both. Most AL proteins analyzed are composed of light chain or their fragments. Condition of deposition of AL proteins, plasma cell tumors, light chain are produced in excess by tumor cells. Certain part of immunoglobulin light chain with mutation here, with mutation in the germ line of the gene have a cardiac tropism. They undergo proteolysis with modification with allow them to be transformed into a quaternary form and facilitate their aggregation with the addition of GAG and SAP, as well as the association of several factors activating their fibrinogenesis. These have a cardiac tropism and are cardiotoxic here. What is the diagnosis of amyloidosis? can say that the clinic of symptomatology, clinical symptomatology of the amyloidosis, we can see that it is the symptomatology is systemic. Donc we can describe renal damage with proteinuria, nephrotic syndrome, and chronic kidney disease, peripheral neuropathy, autonomic neuropathy, numbness, paresthesia, and dysesthesia. Lung with dyspnea, cough, and hemolysis. Gastrointestinal symptomatology with diarrhea, malabsorption, constipation, jaundice, and or melena and occlusion. Spleen and liver, we can see hepatosplenomegaly and elevated of liver enzymes. Cardiac with dyspnea, exertion, diastolic dysfunction, hypotension, and arrhythmia. For the kidney involvement, at the first, there is a proteinuria which may be asymptomatic, but after one may have a nephrotic syndrome, has a progressive onset. It can be pure and deep in most cases, but can be associated with microscopic hematuria and arterial hypotension if association with vegetative neuropathy or an adrenal involvement and or functional renal insufficiency not exceeding creatinemia higher than 14 milligram by liter. But also one can have a table, a case or a table of a rapidly progressive glomerulonephritis with large kidneys in the storm amyloid and renal insufficiency may be terminal, but the patient will keep this deep nephrotic syndrome for a long time despite the beginning of hemodialysis and the need for long-term hemodialysis and or histological evidence at the large stage that will mark chronic terminal renal failure. Another symptomatology is the interstitial involvement with polydipsia syndrome with associated with glucosuria and high blood pressure may be present with vascular involvement that may be associated with AA amyloidosis, but also with AL amyloidosis and cystatin C amyloidosis, which is evocative. Here we can see the most organic symptoms of AA amyloidosis, and it's generally start by kidney damage with nephrotic syndrome and renal failure. Second one, thyroid disease with water. Also with always with gastrointestinal disease, which can be asymptomatic at the first, but after at the end we have diarrhea and malabsorption syndrome. We can have neurological damage, peripheral neuropathy, and carpal tunnel syndrome, and we can have hepato and splenomegaly with hepatic dysfunction. We can have adrenal damage and adrenal insufficiency, and the cardiac damage not be often and not be the symptomatology we have currently in AA amyloidosis. But in AA amyloidosis, Cardiac symptoms are the first, with shortness of breath, fatigue, palpitation, and edema. We can have also weight loss, diarrhea, and sleep apnea syndrome. It can be associated with hepatosplenomegaly and icterus, with peripheral neuropathy, cognitive difficulty, and carpal tunnel syndrome. Renal symptoms are not, we can't often have renal symptoms, but it can be associated, and the frequently symptomatology is proteinuria, nephrotic syndrome, high blood pressure, and renal failure. What are the sites routinely biopsied for histological diagnostic of amyloidosis? We can have in the department, we can do very easily abdominal fat, periumbilical, rectal biopsy, gingival biopsy, and at the end, kidney biopsy. Renal biopsy is an anodinal procedure, but if the biopsy is done, we are more than 90% sure of having a positive diagnosis. Special staining is the red Congo. Here, red Congo plus the tissue biopsied, and we have the importance of birefringence. Birefringence is a fundamental diagnosis criterion for amyloidosis. The ability of amyloid deposits to polarize light allows pathologists to distinguish these deposits from other type of protein deposit or tissue lesion. This characteristic is essential for making an accurate diagnosis and differentiating amyloidosis from other kidney disease. Here we have the microscope of birefringence here, and here we can see this color, the coloring of amyloidosis between green and yellow. For doing diagnosis, we can usually do medical imaging. Imaging techniques are also used to assess the impact of amyloidosis in different organs. We can use ultrasound used to assess the size and function of organs, particularly the heart and kidneys. Scintigraphy and PET scan, technetium pyrophosphate 99 MTC. Scintigraphy is used to detect cardiac amyloidosis. Cardiac MRI used to assess the impact of amyloidosis on the heart muscle and to detect structural abnormalities. The three specific radiotracers, 99 MTC, DPD, technetium diphosphonate, 99 TC HMPD is technetium hemathyl propylene amine and 99 TC PYP, technetium pyrophosphate. Technetium pyrophosphate scintigraphy is one of the most commonly used methods for diagnosis cardiac amyloidosis. This technique detects amyloid deposits in the heart. The patient is injected with 99 MTC, which binds to the amyloid deposit, enabling precise visualization using a gamma camera. Another technique is data state scintigraphy, which uses um, somatostatin analog labeled with gadolinium 68. This method is particularly useful for accessing amyloidosis associated with neuroendocrine tumors. It can visualize amyloid deposits in tumor tissue and access the extent of the disease. FDG scintigraphy is a positron emission tomography PET imaging technique that can also be used to access amyloidosis. FDG, a fluorine labeled glucose analog, is taken up by metabolically active cells, including those affected by amyloidosis. This method makes it possible to access the metabolic activity of affected tissues. PET scan uses radioactive tracers to detect amyloid deposits in the body, in particular tracers such as flumetamol and Pittsburgh compound B. It says BIP, have been developed to specially target amyloid deposits. These tracers allow non-invasive assessment and can provide information about the extent of the disease. The advantage of PET scan only disadvantage cost. Non-invasive, unlike biopsies, PET scan doesn't require surgery, which reduces the risk of the patient. Accurate visualization, it allows real-time assessment for amyloid deposit in different organs, facilitating differential diagnosis. Disease monitoring PET scan can be used to monitor the progression of the disease and the effectiveness of the treatment. MRE is particularly useful for assessing organ involvement in cases of systemic amyloidosis. It can be used to examine the extent of amyloid deposit and to assess the function of affected organs. Mass and other techniques, mass spectrometry principle and method, it is based on measuring the mass of ions. Samples are ionized and then separated according to their mass to large ratio. The main methods used to analyze amyloidosis. After biopsy, using laser microdissection, the amyloid regions are excised from paraffin-embedded tissue section. The proteins present in the paraffin-embedded samples are then extracted in a buffer containing sodium dodesulfate as a detergent. The solution is then mixed by ultrasound and heat until an homogeneous solution is obtained. The proteins are then captured on a hydrophilic resin using a technique known as suspension trapping, S-trapping. With the addition of trypsin, the proteins are cut into shorter peptides with elute form from the resin and whose mass is determined by tandem spectrometer. In this state-of-the-art method, peptides are first separated by liquid chromatography according to their hydrophobicity. Then their intact and fragment mass is determined by tandem spectrometry. After that, specialized software analyzes the recorded mass spectra, enabling the peptide and the proteins from which they originate to be identified. Mass spectrometry is very interesting when the nature of the protein has not been identified with immunohistochemistry and immunofluorescence. It is an essential tool to be developed in our country to label hereditary amyloidosis such as alpha fibrinogen, cystatin C, apolipoprotein 2 and 1, etc. When we suspect amyloidosis, extracardiac amyloidosis, we can do subcutaneous fat. If negative, other organs can be solicited for doing biopsy. After confirmation, Congo red with yellow-green birefringence and immunochemistry and immunofluorescence. If we can't have the name of the protein, we can do a mass spectrometer. If we have AA amyloidosis, we can research an etiology, inflammatory, infectious, or hereditary cause. If we have AL amyloidosis, we can do bone marrow, proteinuria, bench-Jones proteinuria, and free light. If we have hereditary protein, we can do genetic test. If it is cardiac amyloidosis, we can think about AL amyloidosis, light chain, or at ATTR amyloidosis, even can be a mute ATTR or wild ATTR. Thank you for following with me this second video dedicated to amyloidosis. On your keyboards for questions and comments. I say goodbye to the third video on this. Take care of yourself. Salam.